And good afternoon, everyone, and welcome to today's session. My name is Brian Hammer. I'm the Vice President for Membership and Business Services here at NAACOS, and we're delighted to have a great conversation today with our friends at Bamboo Health. And today's webinar is entitled, So What is the ACO REACH Model? What is required and how real-time data and actionable interoperability can help? It's a mouthful to say really fast, but I got it out, no problem. Today, we're going to start with a little bit of housekeeping items. The first thing up for bids here is, thank you, Molly. Molly's running the show for us today. So today's housekeeping items. So the speakers will present for approximately 45 minutes. And at the remainder of the hour, we will take a Q&A session. But if you're really squirrely up front and you really can't wait to ask a question, you're happy to do so via our written submission questions tab on your dashboard to the right of your screen at any time during the webinar. So feel free, let her rip. During the Q&A session, you can also raise your hand feature on the dashboard to ask a live question. Today's session is being recorded, so the slides and recordings will be made available on NAACOS's website, usually within 24 hours. And once they are posted, you will receive an email when they are available. With that, I'd like to introduce to all of you Molly Kane from Bamboo Health here, who is the Manager for Government Affairs and Strategy. Molly, the floor is all yours.
Awesome. Thank you so much, Brian. And thank you to everyone who is in attendance here today. Really appreciate you taking some time out of your, I'm sure, busy schedules to listen into today's webinar. And just as a heads up, I am going to turn my camera off now because I want to make sure from a bandwidth perspective that my screen share does not end up freezing up, but just wanted to say a quick hello. And as Brian said, my name is Molly Kane, and I work on federal government affairs as well as strategy over at Bamboo Health. And with that, we will kick off today's presentation. So before we dive into the actual content for today, I did want to take just a moment to introduce Bamboo Health. And just over a year ago today, Appriss Health acquired PatientPing. And Appriss Health was well known for delivering cloud-based care coordination software and analytics solutions, really focused on prescription drug monitoring and behavioral health and substance use disorder solutions. And on the flip side, PatientPing was known as a care collaboration platform that connected providers to seamlessly coordinate patient care in real time and collaborate on shared patients through a comprehensive suite of solutions. And now the two companies are able to bring the best of both of their solutions together as Bamboo Health. And as Bamboo Health, we provide one of the largest, most diverse care collaboration networks in the country. And our network enables providers to improve whole person care, really with a full view of their patients, including physical and behavioral health, all within the clinical workflows. And ultimately, the goal is to improve health outcomes and provide more efficient and effective use of resources. So as part of that, our mission is to enable customers to optimize value-based care outcomes by delivering information, actionable insights, and support for the delivery of whole person care, and really through bringing together payers and providers, so encouraging that collaboration. And now with that, let's jump into the content for today. So the objectives for today's webinar are going to be to review the recently announced ACO REACH model that CMS unveiled towards the end of February. And this will include reviewing its incentives and requirements, particularly compared to direct contracting. And then from there, we'll discuss the concept of actionable interoperability, including what it means, how it can be achieved, and ultimately why it matters, particularly with respect to effective care coordination. All right, so let's get started. So what really is new for value-based care in 2022? And as crazy as it sounds, as we look ahead to 2023. So while we're of course living in an ever-changing healthcare ecosystem, one particular change of note, and the reason we are here today, is the shift from the global and provider direct contracting model, which is GPDC, or even just direct contracting for short, to the ACO Realizing Equity, Access, and Community Health model, which is abbreviated as ACO REACH. So stepping back for a moment, direct contracting was introduced in 2021, so last year, joining the Medicare Shared Savings Program, or MSSP, and the next-gen ACO model in the high-risk value-based care space. But shortly after direct contracting was announced, CMS phased out the next-gen ACO model, and with it closing out the end of 2021, left MSSP and direct contracting as the two primary options for organizations looking to participate in what I call high-risk value-based care. But ultimately, direct contracting itself was met during the first year with fairly mixed feedback, and ACO REACH can be viewed as CMS's response to this, with the direct contracting model really shifting into this newly announced ACO REACH model. So now looking at the bottom of the screen here, just wanted to highlight a few key dates. So the model will begin on January 1st of this coming year, and it is currently planned to run for 4 performance years. So looking at performance year 2023 through performance year 2026. And the application period for the model ran from March 7th to April 22nd, with applications now closed and awaiting decisions from CMS. Once accepted, applicants will have the opportunity to participate in an implementation period from August 1st of this year through December 31st, but this is not required. And then all prospective participants, including any current direct contracting participants, must meet the model's requirements by January 1st, 2023 in order to actually be able to participate. So why ACO REACH? And now that we've kind of reviewed a high level of the basics of the switch from direct contracting to ACO REACH, let's get into a bit more detail around why CMS moved to this model and how it ultimately will be different from what we've seen with direct contracting. So CMS designed the model with the hopes of using ACO REACH to inform future innovations and updates to value-based care, including potentially updating the Medicare Shared Savings Program. And the ACO REACH program really is meant to build upon some of the key goals and learnings of direct contracting, with it primarily focusing on these bullets that we see on the right here. So the ACO REACH model stands out because it focuses really heavily on advancing health equity to bring the benefits of accountable care to underserved communities. It also promotes increased provider leadership and governance to continue the momentum of provider-led organizations participating in risk models. And then finally, it works to protect beneficiaries and the model through enhanced participation vetting, monitoring, and transparency. And we'll dive in a bit more to some of the changes between ACO REACH and direct contracting as we go through the rest of this presentation. But first of all, who can actually participate in ACO REACH? So very similarly to direct contracting, the ACO REACH model offers 3 different types of participants: standard, new entrant, and high needs population ACOs. On the standard ACO side, these will be organizations that have substantial experience serving original Medicare members, including Medicare only and dual eligible beneficiaries, who are typically aligned to an ACO through either voluntary or claims-based alignment. And these organizations will really be ones who have gained their experience through participation in other shared savings models or innovation programs, or they could be new organizations that are actually composed of existing original Medicare providers and suppliers. So the ultimate point of this standard track is to really focus in on entities that have a lot of experience in serving these Medicare populations. And next up, we have new entrant ACOs. And these will be entities that have not traditionally served original Medicare members, so truly kind of to the name, new entrant. And these organizations will likely rely more on voluntary alignment during the first few years for their member populations with limited claims-based attribution. And then finally, on the right-hand side here, we see the high needs population ACOs. And these will specifically be organizations that have experience serving original Medicare patients, so similar to the standard track, but they will have experience in serving patients that specifically have complex needs, including in many instances, those dually eligible members. And in this high needs population ACO model, members will be attributed to their ACO through both voluntary and claims-based alignment. And these organizations are expected to employ care models that are tailored to these complex needs patient cohorts, such as through the programs of all-inclusive care for the elderly, frequently referred to as PACE. And now within each of these participation types, if we're looking towards the bottom end of this slide here, you can see that there will be two risk options, professional and global. And again, this goes back to direct contracting, but in each of these options, participating providers accept Medicare claims reductions and agree to receive at least some compensation from their ACO. So looking over onto the professional side, this will be a lower risk sharing arrangement. So it's 50% savings and losses with one payment option for the participating organizations, which will be primary care capitation. And this is a risk-adjusted monthly payment for primary care services provided by the ACO's participating providers. Now, on the global side, this will be a higher risk sharing arrangement, so 100% shared savings and losses. And one other thing that's a little bit different on the global side is that there will be two payment options. The first being the same as professional, that primary care capitation payment. But then there also being an option of total care capitation payments, which is a risk-adjusted monthly payment for all covered services, including specialty care, provided by those ACO participating providers. It's just a little bit of a different in terms of the risk options, regardless of which type of participant or track an organization chooses to go with. All right, so now that we have a sense of what types of participant tracks are available under ACO REACH, what are some of the key updates to the model, particularly thinking back to the fact that this really is meant to be a revamping of direct contracting? So the ACO REACH model really is meant to underscore the current administration's focus on health equity and moving towards increasingly provider-centric organizations and models. And based on this, CMS has introduced some key updates to the model with several categories of note that you see here on the screen. And the first, and probably the one that's getting the most attention, is the health equity bucket of changes. And this model includes a benchmark adjustment to better support care delivery and coordination for patients in underserved communities. It also requires that each participating organization will have a health equity plan, and this plan must include identification of health disparities and specific actions intended to help mitigate the health disparities that they have identified. And then finally, CMS will identify underserved beneficiaries using a composite measure that incorporates a combination of area deprivation index and dual Medicaid status to help focus in on some of these historically underserved populations. Now, on the governance side, so the right-hand side here, one thing to note is that at least 75% of each participating ACO's governing body must be held by participating providers or their designated representatives, really to ensure that participating ACOs operate as provider-led organizations. Now, this was something that was also included under direct contracting, but with a lesser percentage requirement. So in direct contracting, providers only needed to account for 25% of an ACO's governing body. And again, this really is just indicative of CMS's focus on ensuring value-based care and other risk-sharing models truly are focused on the providers that are ultimately responsible for patient care and outcomes. Now, on the discounts and quality withhold side, Just a couple of changes to note here. So first of all, in response to feedback from provider stakeholders in direct contracting, CMS has reduced the discount in the ACO REACH model to range from 2% to 3.5% over the duration of the model, compared to in the direct contracting model where it topped out at 5%. And CMS also has reduced the quality withhold to 2% for performance years 2023 through 2026, which is again compared to a 5% quality withhold in direct contracting for those same years. And then finally, on the risk adjustment side, CMS has adopted a static reference year population for the remainder of the model performance period. And using this has capped the ACO REACH model's risk score growth relative to the demographic risk score growth so that the cap is appropriately adjusted based on demographic changes in the underlying population over time. So again, kind of ties back to that whole health equity focus and ensuring that populations that may be underserved, depending on their demographics, are still able to be best served by this model. All right, so with just 7 months to go before the beginning of the ACO REACH model for performance year 2023, what should organizations be focusing on to prepare for success? And one of the key considerations in striving for success really is to ensure that your organization implements scalable and broadly applicable strategies that will prepare you for success not only in ACO REACH, but also in any other future value-based care models or changes as the industry continues to develop. And ultimately, these core strategies come down to two buckets: maximizing revenue and maximizing shared savings. So on the maximizing revenue side, organizations should focus on things such as beneficiary engagement tactics that support retention, and processes to support maximizing of quality scores. And on the flip side, for maximizing shared savings, organizations should focus on implementing care management resources and processes that minimize avoidable utilization, as well as beneficiary engagement tactics that support proactive preventative care. Now, for all of these strategies, an important component for success is, of course, the availability of timely, actionable insights on patients. And these, in order for them to be successful, must be delivered in a meaningful way to these care organizations. And so with that, we need to start thinking more about, when we're thinking about success in ACO REACH and more broadly in value-based care models, how this timely, actionable information really plays a role within each organization's success and better enables providers to make decisions for and with their patients based on multiple factors, including things such as social determinants of health or behavioral healthcare elements. So in a world where patients are seeking care across a variety of settings and organizations, and with each of these organizations maintaining their own separate systems or EMRs, access to information on these patients is incredibly dependent on interoperability. And there's been a major push for interoperability, particularly over the last 10 years. And I think we all can agree that we have made huge strides from our starting points. But that being said, we now really are at a point where the focus needs to shift just from interoperability in general to interoperability that actually delivers value for patients and their providers. And at Bamboo Health, we like to call this the shift from foundational interoperability to actionable interoperability. And so foundational interoperability is really the base upon which all interoperability depends, but at the end of the day, isn't going to be where providers and their patients are seeing actual value. So you can think of foundational interoperability as things such as data quality, data standards, data exchange protocols, and privacy, security, and compliance requirements. So kind of the true concrete foundation upon which interoperability must be built. And then actionable interoperability, on the other hand, is really the point at which interoperability truly delivers meaningful support for providers and their patients. So if you're taking a look at the 4 bullet points for actionable interoperability, starting with process automation, this is really, does the data exchange drive task completion? And then with activity triggers, does data exchange drive the right clinical or administrative action? For cognitive context, is this the right data delivered where it can be acted upon? And then for what we call temporal context, is the data available to the right person where it can be acted upon? So just thinking through, really moving from just having interoperability and data available to delivering and formulating it in a way where it actually is able to be used by providers and benefit patients. All right. Excuse me while I take a little sip of water there, but double clicking a little bit more into actionable interoperability, how does it actually truly impact patient outcomes and provider experience? So if we think through those 4 cornerstones of actionable interoperability that we just reviewed on the last slide, these items in turn should build upon foundational interoperability. They should leverage real-time data to surface clinical and contextual information. They should deliver decision-ready analytics within a provider's existing workflows, and they should also account for patient preferences. And when you combine all of these actions and criteria, this means that in practice, providers are able to collaborate with their peers and with their patients more seamlessly, resulting in an increased closure of gaps in care, the improvement of patient health, and the reduction in the overall total cost of care. And so really to contextualize this with an actual example, let's walk through an ED patient use case for what we see today versus what we should ultimately see as we move down the path of increasing actionable interoperability. So if you're taking a look at just a very simple use case for when a patient presents to an emergency department, at the very base for where we are today with interoperability, you'll see that, if the patient follows up with their PCP, treatment information is then available to that provider. And then in some cases, the emergency department will also proactively send information to the PCP, but this doesn't always occur. And when it does, it's not always complete or contextualized. So oftentimes really just reinforcing those silos in different settings of care and forcing the patient to really be their own advocate in terms of delivering their healthcare information to the right providers. So now if we're taking a look at where we kind of are today, so you'll see here a couple of additional areas on this workflow. And basically interoperability, sophistication, and utility has grown, and hopefully as a part of that, there are now additional members of a patient's care team that are involved in something such as an ED presentation and treatment, either from the payer or provider organization, such as a care manager. And hopefully that care manager is then able to be notified of the emergency department visit, and some actionable information ideally is passed along to the PCP or other managing provider. But that being said, and kind of thinking back to the last workflow of this, the information, even if it is shared, is not going to be standardized. It's not always going to be timely, and it's not always going to be the useful information that providers need to make care decisions. So now taking a look at where we should be and really thinking through with ACO REACH and other value-based care models, we now are incentivized to contextualize the patient experience even more and really accounting for things such as food insecurity, transportation, other social determinants of health factors, and other demographic information. And this information, along with analytics, risk scores, open care gaps, and other patient context, really is meant to help contextualize the activity all parties need to be able to take their role in supporting the patient. That being said, that still doesn't really get us to where we really should be. And so taking a look at this kind of final diagram of an ED event, oftentimes you'll see that third parties are often needed to close the loop between the ED, care managers, and the managing providers or PCPs. And ideally, interoperability would result in solutions that provide discrete directions and activity prompts specific to that patient at that moment in time. And in an ideal world, these solutions would also automate mundane activities wherever possible, really allowing providers to focus on why they became providers in the first place, to focus on patient care. An ideal solution would also ensure consistent information is shared across the entire care team within the care continuum, allowing for interventions at all of the high value moments in care where we see failure points existing frequently today. So at Bamboo, we have done a lot to leverage our networks, particularly with some of our solutions such as pings, our real-time notifications, and our PDMP solutions to provide actionable intelligence at high-value moments in care. And you can see this from the two examples provided on the screen. But I really want to highlight that our work doesn't and cannot stop here. We really need to, both within Bamboo, but also as the industry as a whole, work to do more for interoperability as it relates to care coordination. So at Bamboo, some of the ways in which we're working on this is by increasing relevant social determinants of health and other information to better equip care team members, actively integrating behavioral health coordination needs into provider standard work, engaging directly with patients and with their family and friends to help support their care journey, continuing to grow distribution and access to timely standard of care gaps that exist, and then finally automating information sharing and documentation to all parties to ease that burden on providers and let them focus on their patients rather than their managing systems. So with all of this in mind, how is interoperability likely to evolve over time? And really thinking about the ACO REACH model, one of the things that it will hopefully do is accelerate the drive for standardization and adoption of social determinants of health data and networks, as well as attention to the importance of behavioral health information, access, and standards of care. Because as we look at the focus on health equity, these really become integral parts of any solution that furthers the patient care experience. And as we look ahead, the near-term and midterm focus really will be on the evolution from foundational interoperability to actionable interoperability, and then ultimately to whole person care. And you can see here kind of a little breakdown of how we envision each of these buckets advancing over both the next 1 to 2 years, as well as in the midterm over the next 3 to 5 years. All right. And so at the end of the day, what do we think is the future of value-based care and of interoperability? Which is, of course, a very big question. But I think one thing that we really can all agree on is that the industry is continuing to trend toward an increase in value-based care models, as well as an increase in interoperability. And ultimately, each of these two further drive the other. And as a part of this, the work of providers really isn't changing with ACO REACH as compared to other high-risk value-based care models. However, the incentives to treat high-risk patient populations really are increasing. And this is core to what CMS has been trying to do with a number of their value-based care payment models and what we can expect to see them continue to do in the future. And at the end of the day, the emphasis on care coordination will be important for all patients, particularly those in high-risk populations, but the benefits may not be fully realizable without the help of actionable interoperability. And with that, this wraps up our presentation portion of today's discussion. And now we will be able to open it up to questions, and I will hand things over to Brian to help field some of those questions.
Okay, well, thank you very much, Molly. I appreciate that. Let's see, we have a handful of questions that have come through here. Let's see. Okay, first one here talks about how will the REACH model help advance the adoption of actionable interoperability?
Yeah, absolutely. That is a great question. And I really think this goes back to the REACH model's focus on healthcare equity and health equity in general. And as a part of this, its focus ultimately on social determinants of health, behavioral health, demographic information, all of these things that are brought together to further health equity. And as a part of this, I mean, we see directly with the ACO REACH model that incentives to actively develop these sorts of models to support those high risk, high needs populations are really at the forefront of the model and include, the inclusion of broader types of care team members that need to be brought into the fold to help advance the health of these patients.
Okay, great, thank you. Second question that's come through here is, what hurdles stand in the way of speeding up progress to actionable interoperability?
Yeah, that is a great question. And I think that this oftentimes comes back to what we've seen in the advancements of foundational interoperability and how, while we have reached in some regards a decent base of foundational interoperability in terms of having, data connectivity across different settings of care, we've seen that it's kind of been stagnant in terms of getting that information to a point where it's actually actionable on behalf of those providers. And really this comes down to a bunch of factors, but I'd say cost, complexity, the lack of adoption of unified standards, and then really just the need for clear ROI. We historically have been in a place where we are incentivizing organizations, to deliver fee-for-service care models. And until we really continue pushing for this shift towards value-based care and more whole person care, I think that interoperability will remain a benefit, but not the forefront of the healthcare ecosystem.
Great, thank you. Thank you for that answer. And just as a reminder to folks, we do have several questions coming through. If you do have a question, feel free to raise your hand or just type in the chat function off to the right-hand part of your screen. Another question that's come through is, do you believe the REACH model will better support the integration of behavioral health as a key component to whole person care? That's a good question.
Absolutely. Yeah, that is a great one, and one I'm very passionate about and very lucky to be at a place where we focus a lot on behavioral health. But I think, as you're thinking about both the ACO REACH model and then also contextualizing it in the world that we're living in today. So we've been in a very bizarre few years with COVID and with a number of other, major items going on in the world. And it's become, as a part of this, much more widely accepted that mental health and physical health are inextricably linked together, and that mental health is, really a key indicator oftentimes for the ultimate physical health of a patient. And I'm really excited about ACO REACH because of the focus that it has brought to these factors and to some of the populations that oftentimes are the most underserved from a behavioral health or mental health standpoint.
Excellent, excellent. So here's another question that's come through. How is the static risk score cap different from the DC model?
Yeah, that is a great question. And so at a high level, the static risk score cap is different not only in the percentage changes. So as we went through on the slide, where there's a range of 2.5 to 3% versus the 5% in direct contracting, but ultimately it's also based on the reference population. And so in looking at that static risk score cap, excuse me, the reference population and years that they are looking at are really meant to take a look more in depth at the overall demographics of the population, again, to give a furtherance of that healthcare equity focus. So it's both the percentage change as well as when you're looking at those reference populations, including some additional kind of important contextual information around the overall population.
Great, great. And we have another question that's come through here. Will the implementation of 988, I guess the behavioral health version of 911, impact adoption of the behavioral health side of care coordination and actionable interoperability in your best opinion?
Yeah, definitely. And so for those on the line who are probably also wondering what 988 is, this is exactly, Brian, as you said, the behavioral health equivalent of 911. And this is something that states are currently in the process of implementing, with the national implementation being, I believe, in July of this year. But really, if we're looking at 988 and crisis models, I do think that this is going to help with the overall adoption of behavioral health resources and bringing BH more into the fold of traditional care coordination. So, just kind of first off, we're seeing trained professionals deployed to support patients in moments of crisis. And as a part of that, I think you're going to see that these patients are then able to have more sustained follow-up after crisis events. And there'll be an increased focus from the provider side in receiving this information to get a better whole picture view of their patients to better further their care. So I definitely think that 988 is an incredibly exciting and important endeavor, and then also really is going to hopefully help accelerate some of the strides we've seen to date in whole person care and interoperability for the physical and mental health sides.
Wonderful, wonderful. We have some other questions coming in here. Can you explain further how payment amounts in ACO REACH model are determined?
Yeah, absolutely. So this goes back to the professional versus global tracks that any participants are able to opt into. And so those payment amounts really come down to the ultimate risk model that they choose, where on the professional side, it is the 50-50 shared savings and shares losses, which impacts the payment. Versus on the global side, organizations will be taking on a much higher risk level with the 100% shared savings and rewards, which ultimately means that their payments stand to be able to be, much higher, but also carry a much greater degree of risk within those models. And as we mentioned before as well, the actual kind of delivery of the payment varies between the two models. So you have on the professional side, one payment model available, whereas on the global contracting side, or excuse me, saying global contracting as if it's still direct contracting, but on the global side, you have two options available that will both impact kind of how those payments are received by the participating organizations and providers.
Great, great. And a follow-up question to that is, how are patients attributed in the ACO REACH model? Can you please explain the voluntary alignment period?
Yeah, absolutely. And so for the models overall, so we have the three different kind of buckets of participants. We have the standard ACO, the new entrant ACO, and the high needs population ACO. And for all of these models, they will ultimately use both voluntary and claims-based alignment. However, I will say, and what we've kind of heard from CMS so far, is that the new entrant ACOs, the ones that have typically not served original Medicare members, are the ones that are going to be much more heavily dependent on voluntary alignment versus with the claims-based attribution. And I guess even kind of taking a step back, so how does voluntary alignment work? So basically, this is when a beneficiary is able to elect into choosing a provider who ultimately is part of this ACO. So it's more, allowing for that beneficiary choice during a set time period versus when CMS is able to go in, take a look at claims data, and then attribute populations to different ACOs.
Excellent, excellent. We have another question here. For someone who's new to value-based care, are there resources you would recommend to end users to learn more about these programs?
Yes, I love this question. And so off the top of my head, well, first of all, you have my contact information here, and I welcome anyone to just reach out to me. I am always happy to go down some value-based care rabbit holes. But I would say in terms of resources, I really recommend taking a look into CMMI. So they are a subset of the Centers for Medicare and Medicaid Services. It's their innovation center, and they have wonderful information available on all of their different care models. You're able to kind of, pull reports, filter down into the active value-based care models. I also would love to do a little bit of a quick plug for our friends over here at NAACOS. Yes, Brian, talking about you all, but I personally love the fact sheets and information that you all put out. I think it's an incredibly digestible format and just really helpful for, getting into the space of ACOs and value-based care. So I'd say CMMI, but also do yourselves a favor and check out NAACOS's resources.
We definitely appreciate the kind words, and that's completely unsolicited. So
Yeah.
Thank you. Our policy and education teams work very hard, and to the benefit of our members on the advocacy side and the operation side, and everything that just touches the patient at the end of these models is really what it's all about. So thank you for the plug. And with that, it kind of brings us. I think that is the last question. I don't think there's any others that have come through. So I do want to first and foremost thank you, Molly, and Bamboo Health for taking the time to be with our registrants today on today's webinar. I do see potentially another chat question coming through. Oh no, it's just someone saying great job. So great job to you, Molly.
Thank you.
So throwing that out to you.
Back on now that we don't need to worry about my computer freezing. The joys of working in healthcare technology and working from home. You never know how your computer is going to work.
Of course, that's why I'm as close as I am to my because my microphone goes in and out from time to time. But with that, we'll thank everybody. And in terms of what's coming next, I guess I could shamelessly plug NAACOS events that are coming up. In fact, we have a summer boot camp that is happening on June 16th through the 17th in Nashville, Tennessee. It's going to be at the Sonesta Nashville Airport Hotel. So if you haven't booked your flights yet or your registrations, please look to do that. And if you're also looking to get out of the house, we have our fall conference coming up September 7th through the 9th in Washington, D.C. We're going to be at the Marriott Marquis. So with that, again, thank you to our friends at Bamboo Health. Thank you to everybody who took the time today. Be safe, and we will have these recordings up on our site within about 24 hours, and you'll receive an email notification when that happens. So thanks everyone again, and be well.
Thank you, everyone.